Assalamu alaikum dear doctors. In this video I am discussing about changes at birth and the transitional circulation and cyanosis in the newborn and persistent pulmonary hypertension of the newborn. And these topics are taken from RCPCH Theory and Science book case number 5. Let's start. Changes at birth. At birth, when an infant takes its first breath, the lungs expand and the pulmonary vascular resistance falls rapidly. As a result, blood starts to flow into the lungs and then increased pulmonary blood flow back to the left atrium causes functional closure of the foramen ovale. Occlusion of the umbilical cord removes the low resistance capillary bed and results in an increase in the systemic vascular resistance. Functional closure of the ductus arteriosus usually occurs within the first 24 to 48 hours after birth and is facilitated by the loss of prostaglandin from the placenta, reduced sensitivity of the ductus to of prostaglandins and an increased partial pressure of oxygen after the onset of breathing. Anatomical closure of the ductus arteriosus usually occurs within 3 weeks. So prior to birth, the pulmonary blood vessels have a thick layer of smooth muscle which plays a key role in pulmonary vasoconstriction. After birth, this muscle begins to thin and becomes less sensitive to changes in oxygenation. Any clinical situation, this causes hypoxia, especially in the first few hours of life, with pulmonary vasoconstrictions and a subsequent increase in pulmonary vascular resistance can cause a delay in these normal circulatory changes, potentiating right to left shunting across the ductus arteriosus and foramen ovale. This is known as persistent pulmonary hypertension of the newborn. So, first birth, when baby first birth taken, lung is expand, they are telling, then pulmonary vascular resistance is falls rapidly. Then as a result, flow into the lungs is increased and pulmonary blood flow back to the left atrium causes functional closure of the foramen ovale. So after birth, foramen ovale is closure occur. Occlusion of the umbilical cord removes the low resistant capillary bed and result in increase in the systemic vascular resistance. Functional closure of the ductus arteries usually occur within the first 24 to 48 hours. So functional closure of ductus arteriosus occur within first 24 to 48 hours, and after birth it is facilitated by the loss of prostaglandin from the placenta, reduced sensitivity of the ductus to prostaglandins and an increased partial pressure of oxygen after the onset of breathing. Anatomical closure of the ductus arteriosus usually occur within 3 weeks. Remember, anatomical closure of the ductus arteriosus usually occur within 3 weeks. So prior to birth, the pulmonary blood vessels have a thick layer of smooth muscles which plays a key role in the pulmonary vasoconstriction. After birth, the muscle begins to thin and becomes less sensitive to changes in oxygenation. Any clinical situation that causes hypoxia, especially in the first few hours of life, with pulmonary vasoconstriction and a subsequent increase in pulmonary vascular resistance, can cause a delay in this normal circulatory changes, potentiating right to left shunt crossing the ductus arteriosus and foramen ovale. This is known as persistent pulmonary hypertension of the newborn. Now the second topic, cyanosis in the newborn and persistent pulmonary hypertension of the newborn. Cyanosis occurs when arterial blood contains more than 5 gram per deciliter. Remember, cyanosis occurs when arterial blood contains more than 5 gram per deciliter of the oxygenated hemoglobin. Cyanosis in newborn babies can be caused by a number of pathologies including respiratory cause, cardiac cause, cyanotic congenital cardiac disease, persistent pulmonary hypertension of the newborn and other rare causes such as methemoglobinemia. Now, respiratory causes include severe respiratory distress syndrome, meconium aspiration syndrome, pneumonia, pneumothorax and congenital lung problems such as pulmonary hypoplasia and congenital diaphragmatic hernia. Congenital cardiac disease occurs in 5 to 8 per 1000 live births. Cardiac causes of cyanosis usually present in the first few days of life and include transposition of the great arteries, tetralogy of Fallot and pulmonary atresia, tricuspid atresia. Epstein anomaly, truncus arteriosus and total anomalous pulmonary venous drainage. Persistent pulmonary hypertension of the newborn occurs predominantly in term and post-term babies. Predisposing factors include perinatal asphyxia, meconium aspiration syndrome, respiratory distress syndrome, early onset of neonatal sepsis, polycythemia, hypoglycemia, hypothermia, maternal use of non-steroidal anti-inflammatory drugs, maternal use of selective serotonin reuptake inhibitors such as fluoxetine in the third trimester and pulmonary hypoplasia due to diaphragmatic hernia and oligohydramnios. This question comes that pulmonary hypoplasia, it is a consequence of diaphragmatic hernia and oligohydramnios, and the drugs, that is maternal fluoxetine, causes persistent pulmonary hypertension. Now, hypoxia, hypothermia, acidosis and hypoglycemia all triggers constriction of the pulmonary vasculature and a consequent increase in pulmonary vascular resistance. Often a vicious cycle ensues as increased pulmonary resistance and shunting reduces blood flow to the lungs and oxygenation, resulting in worsening hypoxia and pulmonary vasoconstriction. Commonly, babies with persistent pulmonary hypertension are very unwell and require full neonatal intensive care ventilation to improve oxygenation. Please do subscribe and share my channel everyone. Thank you.